how things have gone across the country. With the impact that the novel coronavirus has had on the elderly, but specifically on those living in congregate care, has been probably one of the most disconcerting aspects of this pandemic, and one that's been both contentious and controversial at times. And so today, our presenters will cover the science and what the data show are the best responses and the things to be concerned about as we go forward, because obviously we are not out of this yet. Michigan is fortunate to have had two expert bodies convened to study both Michigan's response as well as best practice across the country. The governor's task force on the pandemic, as well as the independent review by the Center for Health Information or Health Research and Transformation in Ann Arbor at University of Michigan. We will have people presenting from both of those, as well as other experts in the field, including Sally Pung as the state ombudsman on quality of life for the population. Full disclosure, I was on the CHART expert panel, not because I'm an expert in the field of long-term care at all, but because of my my work in Medicaid and the fact that Medicaid is the predominant payer for nursing homes in our state. So to level set, less than 0.5% of the US population lives in a nursing home, but nursing home residents have accounted for over 40% of the deaths in the US, slightly less, about 32% in Michigan, and about 7% of the overall cases across the country and in Michigan. So this is obviously of concern to all of us, and this is why we're happy to have these presenters today to help you understand where we are in Michigan, where things are going in the country. So I will only be doing a very brief intro of each of them these are very accomplished women who will be presenting today, and it would take me a long time to go through their full bios. So on the IPSR website is their full descriptions of their body of work and their expertise, but I'll only be presenting their titles today. After each presentation, we'll take about 5 minutes for questions, and then there will be an opportunity for wrap-up questions at the very end. So you can, any questions we don't get to, we will respond following the session, but we encourage you to engage on each. Dr. Modi will start off. I'll introduce her first. She will not be able to stay until the end of the session because of a previous obligation. So if you do have questions for Dr. Modi, I encourage you to ask them before she has to sign off. So Lona Modi will begin our panel today. She is the Professor of Internal Medicine and Associate Division Chief at Geriatric and Palliative Care at the University of Michigan, and Clinical and Translational Research Director at the Geriatric Center at the University of Michigan. Dr. Modi?
Yeah, thank you. Thank you for inviting me today to present with all of you. It is always important for me to discuss long-term care. My care as an epidemiologist and as a geriatrician, this topic and this population is near and dear to my heart. So my work and merges the epidemiology, infectious diseases, and geriatrics all together. And I'll be talking more about my research and its translation to policy, and then Kathy will elaborate more on other, and Marianne will elaborate more on our report. So when I think about an infectious, sorry, I'm trying to advance. Sorry. So when I think about infectious diseases or an infection, I think about a host, a pathogen, and a setting. The host in COVID-19 has been our older adults, as was mentioned in the introduction. They do have multiple chronic conditions, and this COVID pandemic has shown us innumerable health disparities that have impacted minorities disproportionately. In terms of the pathogen or the virus, SARS-CoV-2 has been extremely contagious. Transmission in families is common. This virus can pass on from person to person very easily. It was not the case among many other outbreaks and pandemics in the past. And as we know now, COVID-19 infected individuals can shed this virus even when they, and especially when they're asymptomatic and pre-symptomatic, which then leads to unknown or unrecognized transmission. All of these factors then converge in congregate settings, such as nursing homes, where they are already stretched with staff, with suboptimal staffing. They have structural concerns and some process issues. Leadership changes all impact any infection and any application of a policy or research. Furthermore, there's an admixture of short stay population and long stay population, which then makes it easier for transmission of various infections. So I got interested in pandemic planning back in 2007 and 8 when there was a lot of discussion about a potential influenza pandemic. At that time, we sent out my collaborator from University of Nebraska, including a medical student. So I mentor many junior people in my role. We sent out a survey to 2 states, Michigan and Nebraska, to understand their pandemic preparedness. And it was published in a very nice journal, a premier journal, JAMA, for our field. And we showed that only 25% back then had a specific pandemic response plan. Another 25% had started to incorporate pandemic planning within their overall disaster preparedness, but 52% had no plan at all. We modeled a few scenarios. After that, in the other research paper that's titled Progress in Geriatrics, it was published in Journal of American Geriatric Society, and we pointed out weaknesses and vulnerabilities in the sector, as well as immediate need for collaborative planning and dialogue between nursing homes and various stakeholders. This paper was very well received, picked up by many other news media and lay public. Since then, I have worked on many other infections, which has informed the evidence that I'll be discussing next. So as all of you know, urinary tract infection is very common in our nursing home population and older adults in general. And this was a study that was funded, one of the earliest studies funded by the NIH, where we recruited 12 nursing homes in our beautiful state of Michigan, around Southeast Michigan predominantly, and randomized them to an intervention group and a control group. And the intervention was fairly simple. It included what we call preemptive barrier precautions, to wear gowns and gloves while taking care of high-risk populations and helping them with high-risk activities such as bathing, showering, and when splashing is expected, and then conducting active surveillance, which is what we call testing right now, for MDROs and for infections, and then providing very interactive nursing home staff education. And we were, to my own surprise, I was fairly early in my career at that time, there was a 25% reduction in drug-resistant organisms and 40% reduction in urinary tract infections, which then led us to create this nice infographic, CAUTI, catheter removal, aseptic insertion, using regular assessments, training for catheter care, and incontinence care planning. And the reason I'm showing you this is that these kinds of simple infographics have helped us carry our message forward to nursing homes and their patient, staff, and family to help them tackle often complex concepts and topics that are in public health. We then took this intervention national and recruited 500 nursing homes across the nation, of which we had good data from 404 nursing homes, and went on to show that these kinds of simple interventions, such as acronym CAUTI bundle, can lead to 54% reduction in catheter-associated urinary tract infections, as well as 15% reduction in ordering unnecessary urine cultures, which can often prompt antibiotic use. Again, these do not include any medications. They do not include any vaccine. These are core public health type interventions, which then led on for us to think about our emerging short stay population. So when we were doing our early work in our local nursing homes, we realized that really the population is changing rapidly. Now we are seeing more of short stay patients coming from the hospital to stay in the nursing home for about 2 to 3 weeks and then moving on to their home. And this was one of the earlier papers describing the short stay cohort. Again, this was funded by the National Institute on Aging, the NIA. And we showed that, first of all, we cultured people from many different areas using the traditional bacterial culture swab. We collected very detailed clinical information serially over time during their stay in the nursing home. And we recruited a very, very robust cohort of 650 patients from, again, 6 nursing homes, predominantly in inner city Detroit and suburb and nearby areas. And we showed that colonization with drug-resistant organisms, or what we call superbugs, is common in nares, oropharynx, in hands, importantly groin, and in perirectal areas. Another observation that we made was that the longer the stay in the hospital, the more likely that they would be colonized with these drug-resistant organisms. And thus the length of hospital stay, along with the comorbidities and function and presence of indwelling devices, became important in having colonization with these pathogens. And the second key observation we made was that 50% from the hospital came in with a resistant organism. Here we are talking about bacteria, not viruses. And the same number were discharged to the community. Certainly the community, once people got healthy, this colonization reduced over time. But the point was that drug-resistant and bacterial infections are common, and they are coming into the nursing home because of increasing short stay population. The observation then that we made about hand was very important to us and very intriguing. What we showed was we then went on to develop a new cohort of 2 major hospitals, again in Southeast Michigan, tertiary hospitals taking care of very complex patients. This study was funded by CDC, where we recruited 400 patients, followed them over 700 plus visits, got 700 patient hand cultures, and over 4,200 room cultures. So these are swabs that we would bring in our lab. We would have a team who would then analyze the swabs, and we showed that 10% of patients who are admitted in the hospital within 24 hours show bugs on their hands. Either they're bringing it from the community or they're picking it up in the hospital, but they have a superbug, a drug-resistant organism on their hands. Furthermore, 6% acquire a new superbug while in the hospital. So at any given point during the hospital stay, about 13% have a drug-resistant organism. And this is all pre-COVID. The implication we felt was that MDRO on patient hands were common. Furthermore, the environmental room surface cultures showed that, which is the right side of your screen, showed that MDROs on patient hands meant that there were MDROs on frequently touched room surfaces as well. And this paper, again, is online. It is free for download for anybody interested more in this work. Again, this re-emphasized, a similar paper re-emphasized the fact that if getting cultures from patients is difficult, environmental contamination is such that environmental panels, certain areas, if you culture them, would serve as a proxy for patient colonization with drug-resistant organisms. And just to move further with an example, this was a study led by our superstar School of Public Health intern who followed 10 patients going to their rehabilitation and showed that superbug transmission happened in 50% of the 10 total rehab encounters, and there were about 6 out of 35 opportunities where a bug went from patient hand to an equipment or from an equipment to a patient hand. Certainly, we would need to do more genotype and more advanced testing to make sure that they are the common items. Which, again, pre-COVID, then we started working, putting it all together. We felt that nursing homes alone cannot clearly do all of this work on their own. They need guidance, external support to manage their infection prevention. And several of our studies showed that while nursing homes were trying really hard, there were a variation in their infection prevention practices. And we published a slew of papers on that particular variation. But then we come to the conclusion that really, since nursing homes are getting so many patients from the hospital, it is then important that the hospitals and nursing homes work together, and we published this viewpoint in JAMA in 2018 with our hospital team and our infection control team at University of Michigan to describe this concept further. We pitched the idea to AHRQ at that time in 2018 and were funded to run this project, which we call PRISM. Several of you might have heard about this project as well. It is a project where we facilitate information sharing, integration of infection prevention practices in Southeast Michigan. Our goals for this project are to develop a model of an integrated hospital and nursing home infection prevention practices, enhance communication between nursing homes and hospitals so that it's not only patient going back and forth, but it is really the hospitals and nursing homes talking to each other and having a conversation about these patients and exchanging information and best practices. How does our project help achieve this goal? It's a group project. We have nursing home leaders, staff, hospital representatives, public health departments, and our project team. We used to conduct face-to-face educational sessions. Now we do it by Zoom. We learn from subject matter experts and we learn from each other. We hold conferences, and I'll share a couple of pictures with you. We do individualized nursing home assessments for their infection prevention needs. We have on-site staff education and monthly feedback reports, and we give guidance to develop and implement quality improvement projects. And these are some pictures of some really robust conferences and meetings that we have led, both small group and larger conferences. And these are some of my really superb team members who helped me along the way in carrying forward the vision that I have about, that we have about reducing infections in nursing homes. We also did on-site education on hand hygiene, particularly using plates and other props to emphasize the message of doing good hand hygiene, both for healthcare workers, providers, as well as for the patients and visitors. We have a very active website that I can send a link to, where we put in all our up-to-date educational materials, data collection forms, videos, research articles, and so on. And we measure improvements. At that time, and the project was funded to really focus on urinary tract infections and catheter-associated UTIs, but it has created this nice framework and nice platform to then roll out many other initiatives, including discussion about hot topics like pandemic preparedness, which we have done since the start of this pandemic. These are some of the ways that we give data back to individual nursing homes who are part of our program. All of this to say that what we learned along the way, having boots on the ground, was that infection prevention in nursing homes is extremely challenging. It requires resources, dedication, and external support. 2009 onwards, population in nursing homes changed. There were more short-stay patients. Patients carry a lot of pathogens on their body, on their hands. Who helps them with hand hygiene while they are in the hospital or at nursing homes? Common use areas are frequently contaminated. How good is the cleaning? And communication between hospitals and nursing homes can be and should be improved. All of this really informed some of the recommendations that you will hear next about pandemic preparedness in nursing homes. So when COVID hit, in the state of Michigan, our first case was on March 10th, and we immediately dusted off our survey from 2007 and rolled it out to the 400 plus nursing homes in Michigan. And there were some key themes. First of all, our nursing homes were far better prepared in 2020 than in 2007. Far better prepared. They were more likely to have a staff person assigned to lead pandemic preparedness. They had already begun stockpiling supplies. They were providing immediate staff education, better communication lines with local hospitals, public health officials. They had better access to lab facilities, and they knew exactly what was coming their way. They all expressed worries about staff and PPE shortages. This paper was published in April, and I can send links out to those who are interested as well. And then we repeated the survey May 1st week, almost towards the what we call interpandemic period, and we showed that really the nursing homes at that time had started to experience a significant drop in their occupancy rates. They often got multiple and confusing guidelines from several different entities, from CMS, CDC, state, the testing was really a major issue. Hospital transfers became challenging. There was confusing guidance again when to accept patients. Communication with local hospitals and health officials was much better than before, but certainly could be improved upon. They started experiencing staff and PPE shortages. There were concerns about visitation policies by many entities, including our patients. And it was difficult to send patients out for outpatient appointments and dialysis. Just to go a little bit deeper into, for just a couple of minutes, into what they said about their response, and this is the inter-pandemic survey conducted in May. 74% had lower occupancy rates since the pandemic hit. They felt that their response plan, as they developed it and as they were advised, really addressed all or most of the issues among the respondents. 35% had at least one COVID positive resident at the time of the survey in May. They had a designated COVID-19 unit or wing, 78% of those respondents. 66% experienced supply shortages. And in terms of who helped with these shortages, 57% were corporate, 52% were the state and local health department, and 48% from the community. 55% expected staff shortages, exactly what they predicted in early March. And how were these vacancies filled? There were staff, actually, amazing, fantastic staff volunteered to work extra shifts. I know from our own local nursing home experience, people just raised their hands and said that I'm going to do this. This is my calling. There were non-clinical staff filling out different roles. Staff mandated at certain sites to work extra shifts. That was about 47%. 90% were conducting therapies, including physical, occupational, and speech therapy as one-on-one in room. Telemedicine was used by 71% of nursing homes, with 61% using it for the first time. And then they started using several creative methods to help residents stay connected. This is my almost my last slide. We at University of Michigan have a program where we have dedicated faculty providing care at 4 local nursing homes. COVID-19 began to appear in 3 of those 4 sites. The first one happened on March 23rd. So this is a traditional epi curve that you might all have seen. What we describe here on the y-axis is the number of cases, on the x-axis, the date of positive COVID-19 test result. And what we show is the first case happened on March 23rd, and then we conducted what we call an outbreak investigation. We had 29 total cases at the peak out of this outbreak. And on the little small graph on the top, you see our Washtenaw County cumulative confirmed cases. So our nursing home team, under the superb leadership of Dr. Grace Chank and Anna Montoya, and due to our pre-existing collaboration of all the research that we have done, including my mentee, John Mills, were immediately able to organize testing. And that was a time when testing was really in short supply, and our results were turned around within 24 hours. These proactive and coordinated approach then led to immediate cohorting of positive folks, and several of them were pre-symptomatic. This paper was just accepted in JAGS and will be coming out soon, so it's hot off the press. Because of this preemptive testing and immediate cohorting, we were able to limit transmission. Several patients went on after our testing to develop symptoms, so they were truly pre-symptomatic for several days and were cohorted immediately to limit transmission. So we have described, as I mentioned, several papers outlining these experiences of COVID, and we feel that this coordinated approach is an effective measure that actually saved lives, minimized the burden to healthcare system, and saved healthcare cost. So we have several other upcoming projects, including a newly funded NIA project on looking at transmission on SARS-CoV-2 on environmental surfaces. Again, we worked with Marianne and her team, and several of our superb analysts and longstanding investigators in long-term care to develop recommendations for the state of Michigan. We are developing a sweeping research agenda at the national level for professional societies, developing clinical trials infrastructure for nursing homes, and then submitted a few other grants to look at our veteran population, to incorporate resiliency during pandemics, and mentorship, preparing the next generation using NIH grant mechanisms. So I'm going to stop there and take any questions. Thank you.
Thank you, Dr. Modi, so much. At the moment, we have no questions for you. If you wouldn't mind staying as long as you can, and any that come in, we will we'll direct it to you when the time, and otherwise I'll follow up with you after, Lona. Oh wait, we do have one question. Okay, we'll follow up on this one. I can't quite, Arnold, I don't know if you can, it's long. Anyway. Okay, well, thank you very much. And this leads really nicely into the next presenter, Marianne Udow, who led the CHART independent review of the Michigan response, as well as surveys of nursing homes and states across the country. As I said earlier, we are not out of this yet, and we need to learn to be better prepared for the fall. Awesome information, Dr. Modi. Marianne Udow Phillips comes to us as the founding executive director for the Center for Health and Research Transformation at the University of Michigan. And as I said, she led the CHART review, and that's going to be the emphasis of her presentation. And Dr. Modi was an expert panelist as well on this CHART review. So Marianne, if you will go right ahead, thank you.
All right, thank you so much, Kathy, and thank you so much, Lona. I am delighted to be following Lona because you get the opportunity to see the kind of expert advice we got in putting together the analysis and recommendations that I'm about to share with you. I also want to begin by thanking the Michigan Health Endowment Fund, who funded this work. We conducted this study to help the state of Michigan understand the policy, opportunities, and practices to keep our patients safe in nursing homes, to both review what was done in Michigan and help make recommendations going forward. So our study objectives were to evaluate the past nursing home strategy of the state and, as I say, to make recommendations going forward with the input of national best practices, with the input of experts, as you just heard from Dr. Modi, and considering the continuum of long-term care services so that we could make sure that we were minimizing infections, morbidity, and mortality in our nursing homes. This is the team that worked on that study, internal to CHART, and here is the list of our external consultants. As Kathy indicated, she was one of our external consultants, as was Dr. Modi, and you can see our team included economists from the University of Michigan, included Dr. Brant Fries, who is a global expert on nursing home payment structures and quality in nursing homes. It was a terrific team, and I cannot thank them enough for the work that they did intensively on this particular project. The project was designed to be an evidence-based analysis of both what happened in Michigan and what was the best approach to going forward to keep patients safe in the state of Michigan and really nationally. As part of that analysis, we conducted 25 structured interviews with national policy experts, with state administrators, with nursing home leaders, with advocates for patients, with
CMS issued a penalty program for long-term care facilities that don't comply with reporting recommendations. And I only bring this up because, as Marianne alluded to, there's multiple reporting requirements that are required by the federal and the state government from nursing homes, and some coordination of this activity would be much appreciated by facilities instead of adopting perhaps a punitive approach to their reporting recommendations and requirements. The third work group focused on staffing recommendations, and the focus was really on the recruitment and retention. There was a lot of discussion and really, quite frankly, frustration on the challenge of finding, training, and keeping certified nursing assistants, and the recognition that these CNAs play a key role in the delivery of nursing home care. So the ability to recruit and retain adequately trained staff, and then for the staff that are currently working, how do we help support their physical and mental health of the current staff that we have in those nursing homes? Additionally, there was a significant amount of discussion that wage issues may be playing a role in our ability to recruit certified nursing assistants. The work group, however, felt, again, given our August 31st timeline, that the conversation around wage issues were outside of the scope of the committee's purpose and would not be something that we could provide specific recommendations on. But it was something that the work group felt very strongly and the committee felt very strongly should be looked at in the future. And then again, I won't go deep into the quality of life. I think, as Sally will share, what was probably the most palpable by the task force was that uniformly everyone agreed that quality of life for nursing home residents is a significant concern. I think we're all feeling the fatigue of a marathon pandemic, and certainly the stress on our mental health of residents in nursing homes is going to be a critical factor in ensuring their overall success. As mentioned, out of the 28 recommendations, nearly half were ways to better the quality of life. And again, Sally's going to speak more specifically around the recommendations around quality of life, but I know there was a lot of robust discussion and really a lot of heartfelt emotion related to ensuring that those nursing home residents have their mental health and their health wellness considered. So I'm happy to say that the MDHHS, as you probably are aware, has put in some criteria in place around visitation, some improvement in visitation. Again, folks on this call probably are well aware of that. It will be interesting to see with the executive order ruling recently what will be happening to some of these recommendations. However, I think the task force felt a lot of comfort in the fact that the work product that was produced at the end of August has already been utilized to help change policy. Okay, and with that, I'm going to keep my comments short because I do want Sally to also share, and I'm wondering, Kathleen, if it would be worthwhile for me to take comments now or to have Sally present hers, because I think it flows really nicely from my presentation.
So Dr. Chu, thank you for the excellent summary of the task force report and findings. There are no questions in the queue right now, so if we can move right to Sally. And then I believe you are staying on until the end, correct? If questions do come.
I am. Yeah.
Okay, very good. Thank you. So great. I will introduce Sally Pongnak. Sally is the Michigan Long-Term Care Ombudsman, and she did share, as has been mentioned several times already, she chaired the Quality of Life Subcommittee of the Michigan Nursing Home Preparedness Task Force. So Sally, you can load your slides.
So Kathy, again, hopefully you can see my slide up on the screen. And thank you for including the long-term care ombudsman today in the presentation.
We don't have your slides yet, Sally.
Oh, they're not showing. Thank you, Kathy. There's some.
Arnold will be able to, or Cindy will be able to load them if you are unsuccessful. There we go. There we go. There we go.
Great, thank you.
Yep.
Technology is not my forte. So before I start, Kathy, thank you so much for including the long-term care ombudsman today in this presentation. Before I talk about the quality of life recommendations, I was hoping to share a bit about the long-term care ombudsman program because we are a little unique and sometimes people have not heard about our program. So very quickly, I will just share with you some background about the long-term care ombudsman program. So we are housed in the Michigan Advocacy Program out of Ypsilanti, Michigan. Our offices are actually located in the Michigan Elder Justice Initiative here in Lansing. And our state office has 5.7 full-time employees. And our program has 19 local ombudsmen across the state that make up about 16.7 FTEs. So we have I always say that we're small but mighty. As of the end of last fiscal year, we had approximately 30 volunteers and student interns that served as ombudsmen across the state to support those locally paid ombudsmen. So our services are provided in long-term care settings, which include nursing homes, adult foster care homes, and homes for the aged. And so we represent about a little over 100,000 residents that live in those nearly 5,000 settings across the state. What ombudsmen do, a lot of people ask us, what do you do? What is an advocate? So we work to promote high quality of care and quality of life for the people living in these settings. We explain resident rights to residents, families, and sometimes even the staff that are working in these settings. We empower residents to communicate their concerns. Many residents don't want to complain. Some of them are from a generation where you don't complain, and some of them are fearful about sharing their concerns. So we work to empower them and support them to be able to do so. We assist residents in resolving their concerns. And one way we do that is that we advocate for residents and their families. We follow the residents' guidance on what they want addressed, and we only work on their behalf. So we don't seek out those issues. We let residents bring them to us, and then we help them to resolve them. We provide education on long-term care issues to residents, family members, facility staff, and even sometimes the greater community. We promote the best use of best practices, and we inform systemic change through state and federal advocacy, which we've done quite a bit of during COVID-19. And how the work is done, people often ask, how do we get in contact with residents? So we have a geo-routed telephone number, and it's required to be posted in nursing homes, but not in those other types of care settings. Ombudsmen visit licensed homes at least quarterly, and we also go when we need to investigate a complaint. We do additional work beyond that, but that's the bulk of what we do. The program is notified of a complaint survey when it's being done by Lara, and any involuntary discharges that our office receives notification by the state survey agency. And those two things also generate a number of cases for our program. Detailed casework and other services are entered into our database, and we are required to submit a report each year, an annual report that goes to the Administration on Community Living, and then becomes part of a national ombudsman reporting system where data is made available about programs across the nation and the kinds of issues that residents experience and how we've helped resolve them. And I think most importantly that I want people to know today is that our program operates under very, very strict confidentiality. We must have the resident consent in order to take any action to resolve an issue or a concern. And for example, if we went into the nursing home and we saw that a resident was being abused, we have to have consent from that resident in order to report that abuse. And that's very different than most other workers that are going into a home. If they saw that happen, they might be obligated to make a report, but we can't do so unless the resident consents. It doesn't mean that we stop our advocacy if the resident says no. What we try to do is build a relationship with that resident, one of trust and comfort, so that if the resident does become comfortable, we're there to support them if they do make that complaint. And oftentimes we might hint to a provider that abuse prevention training might be in order, or we might ask, when was the last time you trained on this topic? But we certainly can't identify the resident as having a concern without their consent. So I just wanted to share a little bit with you also about the impact of COVID-19 and how that's impacted our program and the people that we serve. So our program did suspend in-person visits on March 13th. We continue to work to provide our services over the phone or through virtual visits. But what we've learned is that virtual visits don't work for some residents, and especially residents living with limited cognition or living with dementia or other kinds of Alzheimer's disease or something like that. So we recently, which I'm really pleased, I guess it was in August, it wasn't too recent, we released guidance to start to resume in-person visits. We worked with the state Department of Health and Human Services and our contract managers at ASA to be able to put together guidance that would safely allow ombudsmen to resume in-person visits. And now in October, we finally are going to be starting our first indoor in-person visit with an ombudsman, because we've focused most of our visits on being outdoors or virtual or window visits to reduce that, mitigate this possible spread of the infection. So starting in March, we saw a very sharp increase in our call volume. We had a 95% increase in calls from April to June compared to the same time from last year. And what we were hearing most consistently were concerns around isolation, care issues, staffing shortages, the lack of PPE or the lack of use of PPE, and visitation and clarification on the current restrictions that were in place. So to respond to COVID-19, our program started to host weekly resident and family calls. And on those calls, we provide updates about executive orders, guidance from the CDC, guidance from MDHHS, LARA, or the Centers for Medicare and Medicaid Services. And we try to answer questions from the participants and allow them an opportunity to share stories. And some of them are heart-wrenching and some of them are very touching at the same time. It's kind of a win on a Wednesday night when you have a family member who's worked so hard over the last several months to be able to see their loved one come back and share with us that they got a visit. And the whole group on the phone cheers for them. So we hope we create that safe place for families to kind of share their experiences. And we've been advocating for quality of life for residents. We provided recommendations to MDHHS staff that are leading the COVID response on multiple issues right from the start. Back in March, we were fortunate to have a good working relationship with the staff, and they looked to us for some recommendations that we thought might be helpful. And we in turn learned from what other states were doing and connected with other state ombudsmen. I remember speaking with the Washington State Ombudsman in early March just to learn what they were doing and what lessons could they share with us that we could learn from. And we've also, our program holds weekly calls with the Aging and Adult Services Administration so that we can relay to them what the resident experience has been like, what's being reported with us so they can hear it and hear the resident's voice. So with all of that said, I wanted to quickly go over the quality of life work group recommendations. So the first one, which we thought was the low-hanging fruit that would be easy to implement, was allowing outdoor visits. And the reason that we included it in our recommendations was that there was some confusion among providers about whether outdoor visits should be allowed or not. At that time, there was an executive order in place that talked about limiting entry into the facility. And most of us would probably think that would mean opening the door and walking in. But for some providers, they felt that maybe that meant limiting access to the grounds in which the facility was located. So we felt that there was need to confirm that outdoor visits were allowed. And we were really pleased to see that MDHHS did so in their September 10th order. We also felt that allowing small group activities or non-contact activities would be really beneficial for residents who were feeling so isolated in their rooms for now many, many months. And again, we were pleased to see in the most recent executive order that came out in 2020-191, it does now allow for limited small group activities. And we think that is going to do a world of good for residents who feel as though they have had no control or no choice in their life because of the limitations that have had to be put in place to protect them. And that kind of goes along with allowing limited communal dining. The same thing in the recent executive order. It now does allow for residents with appropriate physical distancing and disinfecting and wearing a mask that they're able to join each other and be in a dining room together. And just the idea of being able to get up and go for a meal and leave your room, I think will really help residents who are fighting the isolation. The next one was indoor visitation participation opt-in. And what we were asking in this recommendation was that residents be given the choice if they want to participate in having a visitor come into the facility. And we really wanted to recognize that there are some residents who do not want to have a visitor from the outside. They would feel safer not allowing someone to come in and visit with them. So that's why we really focus this as being an opt-in option. Many residents, of course, do want to have visitors, but there are some that would prefer not to. So we felt that indoor visitation should be an option if it's done safely and only with residents who are opting to do so. The next one was to increase or allow for resident small groups like a pod or some of our committee members referred to it as a small family, where they would have the opportunity to live their lives and in very small groups, where these are residents who probably are living on the same hall together, or it might be residents that have conjoining rooms, where they could sit in their room maybe together and read the newspaper or watch a television show together, you know, and again, in a safe manner. If we can physically distance, that would be better, and keep the distance 6 feet space and wear masks. But we were hoping that would give residents an opportunity to have a little choice in their daily routines and feel connected and feel like they're in relationships with other people again. We've talked about increasing virtual visitation opportunities, and we were pleased that the federal government, the Centers for Medicaid and Medicare Services, waived some of their requirements early on for nursing homes to obtain funding out of the civil monetary penalty pool of funds that are available in the state. But we noticed that there were a number of facilities that didn't take full advantage, or there were exceptions that would allow for a larger request that many facilities who probably could have qualified didn't take that opportunity. So again, we really wanted to be sure that facilities fully took advantage of this opportunity, and it would require MDHHS to open up that application process again, which they have done. We were really pleased to see that. And we're hoping that through this opportunity, we could encourage providers to be creative and use different types of applications and portals that are available to them that might be more suited to older adults or people with disabilities, so that they could really take full advantage of a virtual visit rather than just setting an iPad in front of someone. We were hoping that facilities would take those opportunities to seek out those other types of services that might be more beneficial. So the next one is about staff access to creative engagement ideas. And this was a simple one again that I think regardless of the status of visitation in a facility, there are many, many great ideas out there about how we can engage residents and having them choose the kind of activities that are important to them at this time. So one of the recommendations was that the department make available and promote with all provider types the joint provider surveyor training that was just done last week, and it focused around activities and communication for residents. So it's really simple recommendations that we were making that we felt could help those staff members responsible for activities that might not normally have access to those suggestions. So the next one, recommendation 8, has to do with support for meaningful engagement activities. And again, we were looking at groups out there that have put out really creative activity ideas, like from the Alzheimer's Association. You know, Teepa Snow, that is a specialist in dementia care, has a number of ideas. AARP, there are many, many different resources out there, and we just wanted to be sure that those were available and that facility staff were fully aware of them. We also talked about ensuring that residents were engaged in the selection of the activities so that they're meaningful to the residents, and that residents have a choice. And that could lead to things that are very simple that the resident might be interested in. It doesn't always mean that you have to spend a significant amount of money. Sometimes residents just enjoy sitting and talking with someone a few minutes about what is important to them. So we felt including the requirement to assess the residents for their needs would be really helpful to break up that isolation. So the next one we felt was really critical, and this is something that we've received quite a bit of feedback on in our program, which was ancillary service providers. So we made a recommendation as a work group that ancillary service providers be considered essential when a resident is having a decline or a negative outcome due to the lack of having that service be provided. And we were really pleased again that in the MDHHS executive order that was issued on on September 10th, they did allow for ancillary service providers, both medical and non-medical, to be able to enter the building or they could do an outdoor visit if it was possible to provide the services to residents. We just couldn't we couldn't stress enough how important this was. We were hearing from residents that had not seen the podiatrist for 6 months, and one resident was at risk of losing their toe because of an ingrown toenail that had become infected. Other residents who had not received physical therapy, and they might be out of their window where therapy could be helpful to them, especially in the mental health service provisions. We were hearing from a number of residents that they were trying to do the virtual visits, but because of their mental health diagnosis, it made it challenging for them to feel like that was a safe environment and that they were being listened to by only their mental health service provider. So we were really pleased to see that this was implemented in the executive order to allow for those types of visitors to enter the facility when it's really essential and there's possible negative effect on the resident without those services being provided in person. And the next one had to do with visitation volunteers. One of the concerns that we were hearing from a few of our providers on the work group, and we were also hearing it through the Ombudsman program from calls coming into our office, was that it was really difficult for facilities to be able to facilitate outdoor visits or the limited indoor visits that were being afforded through the compassionate care exceptions, because in order to provide those types of visits, facilities have to have a staff person trained in infection control to observe the visit. So that really is pulling critical staff away from care that might be able to be delivered, or you're pulling staff away from other types of functions that they would be doing for the facility. So the work group talked about that and came up with the idea of having a visitation volunteer so that that individual could be trained on infection control, could be trained on all of the PPE requirements, and could be in the facility to help coordinate and schedule those visits, and then also oversee the visits. And facilities could then add to their resources that they have available to promote on-site visitation, whether it be outdoors or indoors. So we hope that that will continue to move forward. We know there was mention of it in the MDHHS order, but we believe in that order it limited the visitation volunteer to only oversee outdoor visits. So we're hoping that that could be expanded in the future. The next recommendation had to do with off-campus health and wellness visits. And again, many of the work group members brought this up as a concern, and we were hearing it through the Ombudsman program, that there were some residents who were choosing not to go for off-campus visits because of the risk that they would have coming back, that they might not be able to return to their same room. Or some of them were even being told, if you leave the campus, we won't be able to isolate you upon return, and therefore you won't be able to return to this facility. That was very concerning. So we had some residents who were choosing not to go to dialysis or not to go to, a specialist appointment. And we can understand why providers were following the guidance that required them, if the resident had a potential for an exposure while they were off campus, they had to quarantine them for the 14 days and be isolated in a room. So we were trying to come up with what would be a reasonable recommendation for residents to be able to have access to these types of settings and appointments that would be necessary. And our next, second to the last recommendation were for window visits. And again, we were asking in this recommendation, or at least we identified that there are some individuals where window visits won't work because of the physical layout of the facility. It may be that the residents are on a second floor or their window doesn't look out upon an area that a visitor would have access to. So this recommendation was simply to ask facilities to make accommodations when residents aren't able to visit out of their room, the window in their room, if they could be moved to a different area in the facility, and could there be a visitation area set up in a common area where a resident one at a time would be allowed to do a window visit so that they had that same opportunity as other people. And we also talked a little bit in our work group about how we accommodate residents for window visits, since for some residents, it's a little terrifying to see when someone stand outside your window. So we were asking for staff to help support residents where they could to make those visits really meaningful for the resident. And then the last recommendation had to do with offering clarification on the June 30th epidemic order that was issued by MDHHS. And as much as all of the members on the work group appreciated this order coming out to allow some flexibilities for compassionate care visits, there was still confusion among some of the committee members about what was being allowed and what wasn't. And we even heard from providers on that work group who were hearing conflicting information. Even when they called the same source 2 or 3 different times, they might get different answers. And I do recall one provider saying, we don't want to take a misstep. We want to do things the right way. And I was really pleased to hear that. I think that's true about most of our providers. They want to do the right thing. They want to support residents, but they're very concerned that if they do the wrong thing, there will be some punitive action against them if the survey agency comes in and sees what happened. So I think that additional clarification could be really helpful so that providers really have a clear path and they know what steps to take so that they can support residents in visitations or off-site, off-campus visits, and really help support residents in their quality of life. So I apologize, I went quickly. I just wanted to leave time for question and answers. And thank you for your interest in the recommendations from the Quality of Life Work Group.
Thank you, Sally. That was a fantastic overview of a really important component for many of us. We have family members or friends that are living in congregate care settings, and we are watching the challenge for the extreme isolation for them. So thank you for you and your committee members for the really good recommendations that came out of the subcommittee. We do have a question specific to your presentation. Is there reluctance or resistance to resident visitation opening up facilities to potential exposure and risk?
Kathy, I would definitely say that there are providers that are concerned about that. We know of a few providers who are very, very selective now in their admission policies about who they will allow in, and some facilities aren't taking admissions at all. So when you think about a new resident coming into the facility and how that will generate additional revenue, and your census will be higher in the facility. When you think about if they don't want to take that kind of risk because they're so concerned about a COVID outbreak in the building, I think there are many providers that are really concerned. They just would probably feel that it's safer to not have visitors coming in. And that might be at the expense of residents who are still struggling with this isolation after 7 or 8 months. But we definitely have heard that. And we've also heard that some of it comes from their corporate office where they're getting directives, or that their local health departments, some of them are saying no visitation. The COVID cases in the community are too high at this time. And so I think they're getting feedback from different sources. And I can understand why they might be a little leery. It's probably better to take the path of least resistance and stay in a safe mode and not have COVID in your building than to have it and then have the media, have an out, it hits the media very quickly. And that's hard for providers, I think, to try to recover from that. So they have to think about that. And then when those survey findings, if that triggers a survey event and the surveyors come into your building, you can get fines and you can end up with immediate jeopardies, and you can end up with even harm level citations that have implications down the road if you want to make changes in your facility. So, as an ombudsman, I fully want to support residents' rights to have visitors in the building, but I do agree that there probably are facilities that are a little reluctant to do so.
Yeah, I want to.
Sure, Marianne, go ahead. Yep.
I just wanted to add to that point because the point Sally just made is so fundamental, and it really, I think, requires that we rethink how we are approaching nursing homes. We have had such a citation-focused and punitive culture when it comes to nursing homes. And if you read just the media reports about nursing homes, they're often described as being, in very negative terms. And I don't want to be an apologist for the nursing home industry, let me be clear, because there have been a lot of reasons for that. And there are certainly, we do have to look at those safety practices. But I think if we approached it with more of a training culture and more of a improvement culture, that's how we turned things around in the airline industry, in the hospital setting. Everybody will tell you that approach to improving quality is not through citations and sanctions, but it is through and encouraging improvement. So I think it's an important lesson for us.
Dr. Chu, you were very, I know, very involved in this work group as well. Do you have anything to add?
No, I would just echo Mary Ann's comment, and Sally as well. Certainly in my role leading quality for a system, I would echo that a non-punitive environment is critical for people to speak up when there are when there are concerns. And I think that, again, the approach that CMS took in terms of civil monetary penalties, I certainly understand the need to put some I suppose more of a hammer approach towards people reporting, but it seems that there probably could be more creative ways to encourage people to share their data and share their information that doesn't involve civil monetary penalties.
Excellent. Sally, there are no more questions specific to your presentation at the moment, so we will move on to the discussion that we're going to have Carrie Cederberg lead. Carrie is the Director of Healthy Aging at the Michigan Health Endowment Fund. Happy to have you, Carrie, and I would like you to now facilitate a discussion among the panelists of where we are.
Do you want me to answer the one that Monica had for us about the data on race?
I was going to do that at the wrap up since it wasn't specific to Sally, if you don't mind, because we'll take questions at the end too. Although it disappeared for me, so I can't see it anymore. But I'll look for it and we'll take it at the end. Thank you.
I know it.
Great. Well, thank you, Kathy. I'm honored to be here with such an esteemed panel this morning. And I look forward to digging in a little more detail in all of this great information that was shared. I thought it would be helpful for folks who have joined us today to get a little bit better understanding of really the two reports. I think there's a lot of consistency between them, a lot of overlap in terms of what we've heard around quality. But I thought it might be helpful also to dig in just a little bit in terms of the differences in those two reports. And so I'll throw that out there before I pick on anyone, if Mary Ann wants to go first, or Betty.
Yeah, well, I'm happy to go first because Betty actually already highlighted one of the differences in the reports, and I think it's sort of illustrative of the differences in our charges and the differences in the composition and the work that we were doing, right? So one of the differences had to do with our recommendation, which was that we didn't need a separate COVID-only facility, and we gave our rationale for why not. And the report of the task force, they came to a somewhat different recommendation. And so, I think that and Betty can speak to this, the task force was composed of a variety of individuals who are different interest groups, who have different stakes in the nursing home field and different perspectives. And it was a group that was attempting to come together on a consensus basis. Our work was done differently. It was a research-based study, and it was looking at the evidence that has been developed so far. And so, there is accommodations that are made in one setting that are different from another setting. And so we were simply looking at what does the data tell us so far? What are the pros and cons? What are the risks and benefits? And I think the Nursing Home Task Force had a slightly different lens to that question. So do you want to speak to that, Betty?
Yeah, exactly. And I did try to highlight that when I spoke because, it has to do with the audience of the task force and the sensitivities that folks have on that task force to various constituents, most likely. I think you see in our report too, we did have one recommendation, as Sally knows, that we spent a lot of time on whether or not COVID positive residents could be placed in non-care and recovery centers, even if those non-care and recovery centers met certain criteria. And so we could not achieve 100% consensus, although we had a majority consensus vote and did put that recommendation forward. But again, it does speak the sensitivity that some members had to that conversation, additional to the same sensitivity related to placement into COVID-only facilities. That was, of course, when I spoke at the Senate, the thing that they wanted to focus on and talk a lot about. I think many folks on the group recognize the feasibility, which is what we tried to reflect in our recommendations, of having a freestanding facility that's open and waiting for COVID patients from a financial perspective, from a staffing perspective, the challenges of having a facility that just stands at the ready, waiting, empty. We saw with the TCF Center that many of these places you take quite some time to come into place, and so having a standing facility open and ready and waiting from a feasibility standpoint, again, I think I'm speaking more for myself now at this point, is somewhat challenging. And there are some other very reasonable options prior to that, as Marianne and her research found.
Yes, when they were having the debate about whether you could transfer patients safely to a nursing home or should keep them in the hospital, they called us in to help and form that debate. So I think we were very complimentary in our work, and I'm delighted. It was kind of an interesting timeline because we were sort of both on the same timeline, and it would have been ideal, I think, if we could have done the evidence-based informed piece first and then handed it off to the task force to look at and make their recommendations. But because of the needs of COVID and our timing, we were somewhat working simultaneously. So we did our best to coordinate, and I think we did a good job given the circumstances.
Sally, did you want to add something?
Here, if I could, please, I just wanted to add that I believe there was some discussion about utilizing existing nursing homes to be those COVID-only centers. And our program, of course, was concerned about the trauma that residents can experience if they're COVID negative and are forced to move to another setting. They lose the environment that they're comfortable with, they lose the caregivers. For many residents, they may lose some of their belongings in that move, in that process. So, I think there was that kind of consideration that also the larger task force had to consider, is the impact on who gets dislocated to make room for a COVID-only facility and what kind of impact that could have on residents.
Yeah, it's such a complex question because, of course, early on, the priority was balancing the physical safety from COVID. But then you think about this patient population and you think about patients with dementia and how disorienting. I mean, even the cohorting idea for a patient with dementia, it's very disorienting. And so what are the trade-offs? These are subtle and complex questions, and they're hard to really address well in a crisis. And they're particularly hard to address well in a very charged political environment that we are unfortunately in this moment.
Agreed. And I think that we heard a lot of that through both of these discussions, right? That balance between really the patient safety and keeping residents, free of COVID, but also how do you balance that quality of life and making sure that there are those opportunities as well. Sally, did you want to add something else? I saw you unmute there momentarily.
Sure, Carrie, sorry, our fax machine's ringing right now. I apologize for that. I just wanted to add that as facilities were cohorting residents, we had calls from a few residents who worked very, very hard to establish a care team on that unit and set their room up in a way that worked for them. And they had some unique needs that were different from other residents. And the idea of them having to move off of that unit was really terrifying for those residents. And we were able to work with the facilities to figure out a way to either replicate that comfort that the resident was experiencing, or in some cases, they actually allowed the resident to stay in that area, which was quite surprising. So I agree with Marianne that even the moves within the facilities that were cohorting were really challenging for a number of residents. There just aren't easy answers.
Yeah.
So Marianne, you and Dr. Modi and the whole CHART team and your slew of experts spent a lot of time really digging into some of the strategies in other states. And thank you for sharing some of those strategies during your presentation. I was wondering, was there something that really stood out to you in terms of the Michigan approach that you think would be important to highlight for the group here today?
Yeah, well, first of all, I really want to credit the department that they wanted to learn what worked best. And they were totally open to our feedback, and they wanted it in rapid time and real time. And I don't, I mean, again, every state's environment is different. Every state's political situation is different. It's a very fraught time. And so not all states were open to the kind of feedback that Michigan was. You know, we've all talked about the data issues and the challenges that nursing homes face with the data. And, you know, our state, frankly, has been late to have good data available relative to other states. We didn't, and for a whole variety of reasons. I mean, it has to do with state budget issues. It has to do with where the investments were made over many years. It's not, you know, necessarily because of COVID. So, you know, we didn't have readily and good data, but as we've tried to unpack it, we've actually learned that probably no state has really good data on nursing homes. And so it's, I think that we've learned a lot about the other states and a lot about their, you know, again, they were throwing everything at it. I don't think anybody knew what the right things were to do, but there are some states that had more resources and have invested over time in more resources than Michigan, and some states that have more robust relationships between hospitals and nursing homes. So, you know, those are learnings that we took back to our state, but I just have to give our state tremendous credit for wanting to hear this feedback, whether good, bad, or indifferent, and acting on it. I mean, I see the actions now. We've all talked about some of the actions we've seen come out very quickly, and that's a real positive thing for our state.
Great, thank you. And sorry if I'm getting a little feedback. Hopefully folks can hear me okay. I just tried to dial in and was unsuccessful. So technology. But I thought it would be helpful also to hear from you, Dr. Chu, in terms of your leadership on the task force. Thank you for that. Were there any main takeaways that you had in the process? You shared quite a bit about the task force, so thank you. But if there was one or two things that really stood out to you, I thought it would be helpful for the group to hear.
Well, it was a great group of people. Clearly, there's a tremendous amount of content expertise in the state. You know, again, Roger's not on the call, but, you know, my co-chair Roger, and then of course, Sally and all the other work group leaders. As you know, we've got a tremendous amount of talent in the state related to this particular issue. And so I think being able to combine and put everybody's heads together in a rapid fashion, I think was important. I think the issues, you know, that the crisis has raised in nursing homes, let's say related to lack of adequately trained staff, related to data issues, you know, sharing information, probably not unique to nursing homes. And we certainly have seen that in other types of healthcare related facilities. The other observation I would make is, you know, to look at the issue of nursing homes in isolation from the rest of the healthcare ecosystem is challenging, because it is so much interdependent, and we are so in a health system, I'll speak from our side, or the payer system, we're so interdependent on each other. For instance, the recommendation to keep COVID positive nursing home patients in hospitals as long as possible prior to discharge. As we all know, there are some challenges with that related to the payment system that would make that not as beneficial or more difficult to execute. Let's just say it that way, more difficult to execute. So I think what I learned was we have a tremendous amount of content expertise and a lot of stakeholders that are really interested in this population, and having our state agencies, having Director Gordon, as Marianne spoke, I was very impressed with how the state agencies were taking such an active role and really had open ears during this whole process. And really providing them with expertise, not only on what we would like, but what's feasible, is going to be really important as we really improve the whole healthcare system, not just during COVID, but after COVID. The other thing I guess I would touch upon too is there are things that we couldn't touch on. I think Monica had asked a question about racial disparities in nursing homes, and as you know, Director Gordon is actually on the Task Force of Racial Disparities. And as we had talked about this topic, we decided it was not going to be within scope for our recommendations because there was another task force working on racial disparities and looking at that issue. We didn't touch upon, you know, COVID vaccine distribution in nursing homes, which I'm sure will be a fun topic to distribute vaccine amongst the most vulnerable population that we have. So that was not in our charge either, but certainly a critical issue as we get through this crisis in the next 6 months to a year.
And since you brought up the race disparities, let me answer Monica's question about whether or not we have the data in the chart report, because we are continuing to look at the data. As I said earlier, we're trying to get deeper into analyzing specific nursing home and hub experiences and quality and performance to help inform the state. Unfortunately, we don't have the race or ethnicity data in the nursing home data. I wish we did. I think it's a very important question. What we do know from the national research is that we've seen similar trends in nursing home mortality rates as we've seen in the overall mortality rates in terms of the populations of color and nursing homes located in communities of color having higher rates of cases. Again, the cases we're seeing in the nursing homes very much follow the community rates. And so there is a disproportionate impact. And I think that's a really important question.
Great, thank you. And I apologize, I'm sounding a little bit like a robot this morning. Must be my alter ego. So Sally, I know we talked a lot already about the importance really of quality of life, and I think we've seen that weave throughout both of these reports. And thank you for your advocacy as our state long-term care ombudsman. Was there anything that really stood out to you throughout this process? Maybe one, two, three key takeaways that you'd like to share with the group this morning?
Yeah, thank you, Carrie. I was really impressed when the work group came together. Quality of life was not one of the work groups that had been identified. And when Dr. Chu and Mr. Molly had asked each work group, each task work group member to just share with them what are your priorities, I think nearly most of the participants spoke to a quality of life issue and how this was impacting residents. There certainly were participants on the phone that were concerned about testing and PPE and staffing, which are equally as important topics. But I was just so pleased to see that the task force co-chairs and the department were willing to create a quality of life work group to try to help address these issues and the concerns. I think the collaboration and the consistent responses from regulators and legislators and providers and advocates in my work group was really promising to see that we all were kind of coming from the same place, which was how do we make this better for residents? And so that I think was encouraging. I was really pleased to see that. When I think about the work that we've done and where we've come from, I think it's important that we now take this opportunity to think even more about moving forward. And if we do have a second wave, or we have the flu season that hits, and with COVID on top of that, the transmission could be even greater. I think we just have to always keep in mind that these residents, some of them have been isolated now for 7, 8, or 9 months. And I think we have to maybe take a different perspective on how we protect residents. And is it 100% protection, or how do we then balance quality of life, resident rights, the things they should have freedoms to, with the need to overall mitigate or just reduce the risk. And I think that might be a turning point for us. I think we've come at this as 100% protection. And I think for a lot of residents, they would say, I don't mind taking a little bit of risk. We've had many residents tell us, I would rather die from COVID than die from loneliness. So I think that's one of the things that we touched on, but again, we had such a short time frame to address this, but I think moving forward, we really do have to take those freedoms into play for nursing home residents. They're restricted more than anyone else in our state. And I think this is an opportunity moving forward that we might be able to consider that more. And then the other thing that I think is really important that I was hearing loud and clear from sub work group members was that the communication is really needed. Work group members were sharing with each other over chat all these different links to different resources, because not any one of us was aware of all of the different communications that were out there and the different guidance. And the state has done a fantastic job with the website and putting information up there. But if you are not familiar with where to look for it on the website, it becomes overwhelming after a short period of time. I feel that way when I go to the CDC website, even though I know what I'm looking for. So communication is always a concern on any type of a big project, but that's one area that I think additional communication could be helpful. And I'm really pleased to see that the state has put in requirements that follow CMS's, where we're notifying families and residents now about COVID status in the building. Because early on, that was a huge concern for family members not being able to get through on the phone and then wondering if their loved one was still alive or not. So I think we've made great steps. And I think if we continue to work creative and work collaboratively, we can figure out ways to move forward and serve people even better through this epidemic.
Ellie, and I think that's a great segue into the last question I have really is, where do we go from here? I think you have addressed a lot of that already, Sally, but Mary Ann or Dr. Chu, if you have any recommendations as well for the group.
Well, I'm going to probably defer most of that to Mary Ann because I know that her group is very actively working and assisting, in policy development. I'm hopeful and optimistic with what I've seen so far and the energy and the activity around this particular topic in the state that we're going to have some really wonderful solutions. So I guess I would defer that to Mary Ann.
Well, first of all, I think we're learning so much and we're lifting up an area that I think has long been neglected in our public dialogue. And so in as tragic as this has been, and this is certainly not the reason that we would have liked to have done it, I think the kinds of things Sally's talking about and the kinds of things that Betty and the task force focused on are just such important discussions that we need to be having. So I think this gives us an opportunity, and some of the conversations we're having with the state is how do we think about the whole continuum of long-term care? So I'm hopeful that at a state level, certainly we're continuing our work and our analysis, and as I said, we'll be providing more information for the state to move forward in a positive way. But I think that this gives us an opportunity to think about the continuum of care. How do we keep patients, how do we keep families in their homes and in their communities? Can we rethink things like the PACE program, which has some real restrictions on it in terms of who can participate, but more people could stay in their communities if PACE could be rethought. There's some federal things that need to be done there, but there's some things I think at the state level that can. How do we partner with health plans and managed care organizations to help encourage more of these community-based settings and to provide more support to nursing homes so that they have the appropriate supplies and resources? I think this opens up a whole host of policy opportunities, and I'm going to put it in that positive way. At the federal level, because of this work, we've been able to connect with a lot of the researchers who are working on these issues nationally, and you're seeing more calls come out. In fact, my colleague Robin Rontal and I wrote a paper on this for Bifocal about how do we rethink long-term care financing. I mean, this is the core issue at a policy level. You know this, Carrie, from your work at the endowment fund. I mean, Medicaid is our only financial mechanism for people who need assistance with activities of daily living, right? Medicare was set up to provide very limited support for long-term care, very acute level support for long-term care. These systems do not work together. We need to rethink how we finance and support long-term care going forward. So, I mean, let's hope we have that policy dialogue. I'm not going to predict what's going to happen after November, but we really need to have this discussion at the federal level as well as at the state level.
Thank you, Mary Ann, and we do have Dr. Massey with us today, so I'm sure she heard your message loud and clear as well. So with that, Kathy, I'll turn it back to you to do some final closing thoughts.
Thanks, Carrie. Thanks to all of our wonderful presenters today. This was a really important session on an extremely critical topic for our state. We do have a few minutes for last questions, and I am not seeing one. I just will follow up on the question that Monica asked about the racial ethnic disparity and data specific to the nursing home population. In our recent Michigan Health Policy Forum on when racism intersects health, the state epidemiologist indicated that racial disparity is actually evening out now for COVID overall in our state. It will be interesting to see if we're going to see something similar in the nursing home population, but that data really has not been transparent to most of us. So it will be really good, Mary Ann, if that can be an added piece to all of the excellent work that CHART has done. I am just curious, and I don't know if it's a fair question with 2 minutes to go because we don't have any other questions in the queue, how confident you all that are experts in this field feel about where we are now as fall approaches, with the expectation that COVID is going to get worse and we're going to have, conflating seasonal flu. How much has been learned, and do you feel confident that the nursing homes in general, not just the hubs, but the nursing homes in general are prepared and ready?
Betty, you should start that one.
I do. I think the availability of testing is critical, which is something we obviously did not have, in March. And we certainly know what it is that we need to do, whether or not people will be able to execute on all those things. So I have a high level of confidence. I think people are having the right conversations. Like many of you, I'm a little concerned about the decision of the Supreme Court around the executive orders, only because of the variability that will lead to from a county approach, a county by county approach. I mean, our health system extends from Jackson County to Wayne County, of which there are probably going to be very different opinions about how policies will be enacted in Jackson County versus Wayne County. So I think what's going to be incumbent upon all of us is to stay connected, so we have a singular approach. Even though we may disagree, we have a singular approach based on evidence and science on what works. And that is going to be crucial for us to get through this. We know what those things are. Whether we can be resolute about them is going to be interesting.
Yeah, I would agree. I mean, first of all, I think we know so much more than we knew just a few months ago, and we have implemented better policies and better strategies. And I really do believe the nursing homes want to implement those policies and strategies. They don't want to be in the situation where patients are dying in their facilities. And so I think that we're better than we were. I am still concerned about the adequacy of PPE and whether we have enough supplies. I am very concerned about the chaos at the federal level and the lack of a coordinated uniform strategy for distribution of supplies. I think we can do better on testing. We have some recommendations about adding pooled testing in Michigan, and I think we can do better on that than we have, and I think we will. But I think the hub strategy, as we said, the hubs actually performed reasonably well, even without all this knowledge and without all of the new approaches. And so I think the recommendations that both the task force and we made, and that the department's now implementing going forward, I think will be, a better and safer approach. So I'm cautiously optimistic. I think we still have vulnerabilities.
Well, that was excellent summary. I appreciate you taking that hard question at the end, Dr. Chu and Marianne. And we are a minute over. I will turn it back to Arnold to wrap up for today, but I want to, again, extend my sincere appreciation for you all finding this big chunk of time for us this morning. Thank you.
And much like Kathy, I too want to extend my sincere appreciation for your time this morning, your expertise, your perspectives, and your continued work moving forward. We're nowhere near out of the woods on this, and it's probably only the beginning of such instances and episodes as we move on. So again, thank you all very much. We will be posting both the video and the presentations. Actually, I think the presentations are already on our website, but the video will be posted as well in the next couple of days. And again, thank you to Kathy for her great facilitation of this session. Thanks again to the Michigan Health Endowment Fund. And we look forward to having you on another Michigan Health Policy Issues Group forum. Have a great day.
Thank you.